And welcome. On behalf of Sutter Health and San Rosa Orthopaedics, welcome to tonight's session on neck and back pain. Due to the current social distancing requirements, we've had to pivot our in-person seminar to this online format. But the information will be the same, and we hope you find this session valuable. Our presenter is Dr. Christian Athanassious, a board-certified spine surgeon with fellowship training in spine surgery from Stanford University. Dr. Athanassious completed his undergraduate work at UC Davis, received his MD degree from Drexel University College of Medicine. Dr. Athanassious completed his orthopedic residency at Monmouth Medical Center, where he served as chief resident. He then completed a spine fellowship at the prestigious Stanford University. He's the medical director of the Total Spine Healthcare Program. And Dr. Athanassious has two offices in Santa Rosa, and he treats surgical patients at Sutter Santa Rosa Regional Hospital, where he is the vice chair of surgery. Dr. Athanassious brings invaluable expertise and knowledge about the latest advancements in orthopedic spine operative and non-operative care to Northern California. Patients like Dr. Athanassious for his advocacy of a whole body medical approach to treatment. But most importantly, Dr. Athanassious has outstanding treatment outcomes, and his patients consistently give him top ratings in resolving their pain. So before we get started, just a couple of housekeeping items on how these online webinars work. When you have a question for the doctor, just scroll your mouse, touchpad, or pointer over the little Q&A button. Depending on your configuration, it'll either be on the top or the bottom of your screen. Just click Ask a Question and type it in, and Dr. Athanassious will answer the questions at the end of his presentation. Once the webinar is over, you'll still have a chance to ask more questions, contact the doctor with anything personal, or request an appointment. A survey form will pop up in your browser when this is all done, and just in case it doesn't, we'll email you the survey question form again tomorrow, so check your email. Okay, let's get started with this show. We are so grateful that Dr. Athanassious could make it here tonight to talk to you directly. I'll hand over the screen presenter role, and let's welcome Dr. Athanassious.
All right. Hello, everyone. Thank you so much for doing this webinar and signing in. It's a wonderful opportunity for me to speak to a large group of people about neck and back pain treatment and give people an understanding that there are treatment options. So we'll go ahead and get started, and please keep in mind that you can ask questions as we go along, and I'm happy to answer them afterwards. All right, so neck and back pain treatment. All right. So we're gonna today take a look at the causes of neck pain, and along with neck pain, often people will have radiating symptoms to the hands. They may have numbness or tingling radiating to the hands. They may have weakness in the hands or arms. Additionally, they can have difficulty with walking if they have a problem in their neck as well. And we'll also look at the causes of back pain. Back pain is often referred to in concordance with sciatic symptoms or symptoms that radiate down the legs. Symptoms from the back can go not only down the back of the leg, they can go down the side or the front of the leg as well. There's non-surgical options and solutions, and the majority of people can be treated pretty effectively with these solutions. And there's also minimally invasive surgical options, which have very good outcomes, short hospital times and short recovery times. We can also talk about what life would be like after surgery and what the next steps will be to resolving your neck and back pain. Often I see people in my office that have waited years because of fear that there's no good treatment for their neck pain or their back pain, or that surgical options or non-surgical options are not effective and they have to live with their pain. The purpose of this is to educate everyone out there regarding neck pain and back pain, and to look at the fact that there are valuable treatment options. And if you can understand where the pain's coming from and how we treat it, it will hopefully allow you to be able to be an advocate for yourself and to allow me to help you with these symptoms. So just very broadly, there's a few levels to the spine. We call the cervical spine, which is known basically as all the neck bones, the thoracic spine, which is the spine around the rib cage, the lumbar spine, which is the lower back, and the sacrum, which is the tailbone. The most common areas that people have pain is within the cervical or lumbar spine because these are the areas that have motion. And with motion comes arthritis and instability and areas where we can have pain generators. We also have three curves in our spine. We have our cervical spine, we have our thoracic spine, which is here, and our lumbar spine is here. And if you look, these all work to balance themselves. The cervical and the lumbar curvature match each other, and they basically will balance this thoracic curvature. So when someone speaks about neck pain, they also often speak about pain that's radiating either up over their head or over their shoulders and down their arms. They can discuss it as a deep pain, an electric pain, or electric shock-like symptoms, a stabbing pain. People can wake up with numbness or have numbness throughout the day, and they can have weakness as well. People will come sometimes in with problems with balance. And all of this can come from the neck and can be associated with neck pain in association with radicular symptoms. Anytime that we speak about radiculopathy, we speak about irritation of the nerve root. So radiculopathy is simply the way that we describe inflammation within the nerve roots that come off of the spinal cord. And you can have radiculopathy coming from the neck, and you can have radiculopathy coming from the lower lumbar spine. All nerves go to very typical patterns within the skin. So we call these innervations called dermatomes. And this is a dermatome map. So just like you talk about longitude and latitude in a globe, this is a dermatomal map. And what we can do is we can have a better understanding of where is the disease before we even look at an X-ray or MRI, simply by listening to our patients and understanding, you know, if someone has numbness or tingling going to the thumb, radiating over the forearm here, they may have a problem at the C5 or the C6 level. And we try to correlate the area where people are having pain with what we see on X-ray and MRI, and that allows us to be able to treat our patients better, more effectively, and have better outcomes. In addition to a dermatomal map, which talks about where sensation goes, there's also myotomal distributions. So for instance, the C6 nerve root controls the biceps brachii, which allows us to flex our elbows. And if someone has weakness in terms of flexing their elbow, and they're talking about having pain radiating down over their forearm and down at their thumb, these all correlate together to once again have us look at the C5, C6 level. I talk about the C5 and C6 level very specifically because it's the most common level that someone will develop radicular symptoms, degenerative disc disease, and problems in the neck. Myelopathy is a different sort of pain and disease. This refers more to a problem with balance that occurs from a problem in the neck. Now, when we talked about radiculopathy, that was compression in the nerve roots, which are little rootlets that travel off of the spinal cord, and at each level of the neck and thoracic spine and lumbar spine, there's branches of nerve roots that travel out. They go to the arms, they go around the ribs, and they also travel out towards the legs. Myelopathy speaks about actual compression within the spinal cord. And if you look here at this MRI picture right here, you can see that there is a big, large herniated disc here. And you can see that there is compression on this black cord coming down, and this is your spinal cord, or a person's spinal cord. You can see that the compression here is causing a nerve root injury, and is causing an increased fluid signal and white signal here, which is a sign of a spinal cord injury and damage. The compression that is seen here can be much more dangerous than an actual nerve root problem. Spinal cord injury is much more serious. It does not resolve or heal well and can be permanent. I often can see patients come in that are described that they've been walking independently, and all of a sudden felt like they were walking drunk and had to go to walking to a cane, and then had to move on to walking with a walker. And they feel that their legs are heavy. They feel that they have to have a broad-based gait. We look in their cervical spine or in their thoracic spine, and we can see this kind of picture of a disc herniation or some sort of arthritis compressing on the spinal cord, whether it's in the cervical or in the thoracic spine. And it can be something that needs to be treated in a more urgent fashion. And in some points, if it is an acute injury that happened very quickly, it needs to be treated in an emergent fashion. So patients will also come in talking about hand and arm numbness, clumsiness. They say that there's a change in their handwriting, or they have difficulty buttoning their shirt. They may be dropping objects when they're not paying attention to them. And in very rare cases, they will talk about bowel and bladder dysfunction. So the anatomy of the lumbar spine will now go down to the lower back, is comprised of 5 functional lumbar vertebral bodies, and also the sacrum, which is fused together. And we can see here that this is the tailbone, this is a side view of the spine, and this is a front to back view, and we're looking at the spine from the back. You can see at each one of these levels, there's a bone with discs here, here, and here. And oftentimes, like I said, the cervical spine and the lumbar spine has a lot of motion, and that's why the majority of the disease that happens in the majority of individuals that have problems with their neck and back occurs in the cervical and the lumbar spine. It does not happen in the thoracic or sacral spine, because the thoracic spine doesn't have much motion, and the sacral spine is the tailbone, and it doesn't have any weight-bearing capacity, or it doesn't have the majority of the motion like the lumbar and cervical spine does. This is a more up-close view of what we were just looking at, and you get an idea of the vertebral bodies and the bones here. So if you imagine this could be lumbar 4, lumbar 5, maybe the beginning of the sacrum. You have the nerve roots or spinal cord traveling here, and you have the nerves branching off at each of these levels, going to the arms or legs, depending on which area of the spine you're talking about. This is an anatomy or a bone that looks more like a lumbar spine, but it gives you the general idea that there's a canal, and at each level of the canal, there's nerve root that travels to the right and to the left out of the canal, which controls our sensation and our function. This is a cross-section of the disc, which we look at here. So if you imagine the disc here, okay, this blue area here, and we go back here, there is 2 areas of the disc. There is an outside fibrous layer of the disc, and there is an inside nuclear layer. Now, you can think of it as almost like the jelly that's in a jelly donut. This outside layer holds this compressive liquid or gelatinous layer together. And when someone has a herniated disc, there is a tear of this hard fibrous layer, and this jelly-like substance can squirt out into the canal and cause compression and irritation of the nerve roots. So there are multiple initial treatment modalities that have relatively low risk and that can be used for treatment of spinal disease. Anti-inflammatories, which you can do over the counter, and there are prescription anti-inflammatories as well. Physical therapy, which focuses on range of motion, core strengthening, massage therapy, ultrasound therapy, and traction, and other modalities to try to alleviate nerve root irritation, teach patients how to take care of their core and their spine over the long term, and also teaches patients on positioning and how to go through daily activities without aggravating their neck and back. Epidural steroid injections work to control the pain and decrease the inflammation around a nerve root that may be irritated from compression from a disc, arthritis, from injury, and it will allow the patient to have not only some anti-inflammatory effect directly at the nerve root or the spinal cord region, but also a decreased amount of pain while their body heals. Braces work to stabilize patients. They're effective if there is an instability in the spine or if there's a fracture. So sources of pain of the spine there, and we call these frequent pain generators. So arthritis can be enlargement of the joints. So if you think of about an individual who has arthritis in their hands, they have enlarged knuckles. The problem is that when there's inflammation or increased arthritis within the spine, there's an economy of space. And when the joints enlarge, this puts compression on the nerve roots, and the nerve roots don't have anywhere to go. Stenosis is the way that we describe narrowing within the spine. So anytime that you see the word stenosis, just go ahead and think narrowing. And that is a very commonplace term that you hear a lot. You see it on MRI reports and also doctor's reports. Neuroforaminal stenosis has to do with narrowing. Once again, you have that word stenosis here within the nerve hole. So neuro means nerve, foramen means hole. And that's where we saw that there is areas where the nerve root exits on the right and left side at each level of the spine. And that's where you can see nerve hole narrowing or neuroforaminal stenosis. Degenerative disc disease is the loss of disc height that happens with age. It's very normal to have, but not everyone has pain because of it. And this can also be a pain generator in certain individuals. Facet disease speaks once again about this arthritic component that we discussed. Arthritis causes enlargement of the joints. The facets are one of the joints that are in the spine. And when the facets enlarge, this can cause a narrowing of the canal or stenosis and cause pain. So when you see here, this is the types of pathologic symptoms or symptoms that people may come in or explain that they have. They could have back pain, which is axial back pain describes pain just in the midline of the spine. Radicular pain is pain that radiates to the arms or down towards the feet. It also can radiate, if it's in the thoracic spine, around the ribs and to the chest wall. Loss of balance is the myelopathic symptoms that we were speaking about when the actual spinal cord is compressed in the cervical or thoracic spine. Loss of dexterity can occur from that same reason, and weakness can occur from any of the causes that we discussed before. So there is many new techniques that are used in terms of treatment of the spine. This has shortened the recovery time, shortened the time in the hospital, and allowed for much better outcomes with much less blood loss than has been in the past. There are many different ways to approach one spine problem, and there's many different things to think about in terms of what's the right way to treat a patient. And even when you speak about a decompression of a certain portion of the spine or a fusion of a certain portion of the spine, there are many different ways to remedy and treat that problem. So first of all, if we just start from the neck, cervical spine, a very common procedure, which is an anterior cervical discectomy and fusion with plating, which is the standard now. Basically what happens is from the front of the neck, we go in and we open up the space. We take out that compressed disc that might be pushing on the spinal cord or the nerve root, and we place a spacer in there to align the patient and keep and restore that height. It used to be that we were just concerned with placing a spacer there and just holding that space open. But as we have understood with time is that there's a global balance within the spine. The curves that we spoke about between the cervical, thoracic, and lumbar spine must be balanced in order to give good longevity and to decrease the risk of what people call adjacent segment disease, which is disease in the levels above and below the levels of fusion. With advancements in the way that we measure this and the interoperative computer angulation and measurements, we were able to decrease the risk of adjacent segment disease and also improve functional outcomes. So if we review here, this is that same or similar picture of the MRI of the spine. There's a disc herniation at C5, C6. If we saw this, a person could have weakness in his biceps or her biceps, could have pain radiating down the arm in that C6 dermatomal distribution, or could have problems with balance. You can see here that there was a surgery that was performed to address the concerns here. Now, this would be if someone had multiple levels of disease. And what we're not looking at here is all the cross-sectional views. And in this specific patient, there were problems with the nerve roots at the levels above and below. And we had to address all of those stenotic symptoms to treat the patient. You can see here that the curve was restored and that the cervical lordosis was preserved. So this is a pretty busy slide, but it does show multiple different disease pathologies that we've talked about in the past here in an actual cartoon format. So this is a normal disc. So you can see here there's a normal height. The oval, which is called the neuroforamen, is well restored here. And this is an area where you don't see any clear compression. The degenerative disc here is basically a disc that hasn't lost much height, but when you look at it on MRI, there's dehydration, which tells us that it cannot sustain weight and compression as well. And most likely when the patient bears weight, there's a loss of the space where the nerve exits or the neuroforamen, which could cause stenosis. Disc bulging has to do with just a bulging disc without that outer layer of the disc. As we remember, there's an annular layer, the fibrous layer, and the gelatinous layer. And here, in just a bulging disc, there's not actually a tear of that outer layer. A herniated disc is the tear of the outer layer and that gelatinous material going out into the canal, causing inflammation and pressure on the nerve roots. Disc degeneration here shows that there's not only a loss of the disc height, but also there's arthritic component, enlarged joints, and compression from the bone actually compressing on the neural elements. So for these, a person can start with physical therapy, injections, and there can be different operative treatments such as a microdiscectomy, or in some cases, even a spinal fusion. So lumbar stenosis is a very common disease that occurs in individuals, and it can range from 45-year-olds to 95 years old. It is a slow progressive disease that causes back pain, burning pain, numbness and tingling, decreased ability to walk. Patients will sometimes say that when they walk with a cart or hunch their back over and are able to take the pressure off of their back, they're able to walk farther. Here we see that there is a compressive element. So this is the front of the abdomen here. This is the back here. And this is a cross section, or what we call an axial cut. This is a normal spinal canal with the nerve roots or spinal cord in the middle. And this is called the spinal foramen. And here you can see that there is compression from behind and also in front on the spinal cord or nerve roots, depending on which portion of the skeleton that you're in. Treatment for this can be a laminectomy or partial laminectomy to shave this bone. And often people describe it as a roto-rooter to remove some of the bone or take away some of the ligament to open up some of the canal. And in some cases, patients will need a spinal fusion depending on what other disease they have. Spondylolisthesis is an area of, where the bone is slipped forward. And you can see here that this bone is slipped a little bit forward on this one. And some people have a fixed spondylolisthesis, and some people have a mobile spondylolisthesis. When someone has a mobile spondylolisthesis, it's an indication that not only does a laminectomy need to be performed, but most likely a fusion should be performed as well, as the chance of causing instability after a partial laminectomy is increased. Additionally, you can see in this patient, there's a loss of height. And not only is there a problem within the center canal, but there's also a problem with the nerve roots exiting. And without proper alignment and restoration of height, the patient will not have the best outcome. So a laminectomy or partial laminotomy has to do with basically shaving some of the bone. So here we have a picture of the spine as we see it from behind. And what we've done is here is shaved and removed out the whole portion of the lamina. Now it is rare that I need to remove the whole lamina. I only make a window in the area that is narrow and use a microscope to minimize the surgical procedure to gain the best outcome that we can with the least amount of damage in order to increase the patient's ability to ambulate early and decrease the recovery time. Here, this is a laminotomy, which is a small window that's made just on one side. This can be used because there's just compression on one side. This can also be used in the case where a person has an acute disc herniation, and that acute disc herniation is causing a problem, and we need to enter the canal from a certain portion, and so the laminotomy is used to open up the canal. We shift the nerve roots out of the way, and we take out that fragment of disc. Here we have the idea of a microdiscectomy. So this is what I was just speaking about in terms of a laminotomy. If a person has an acute herniated disc without narrowing in the other portion of the canal, we can do a small laminotomy, move the dural sac out of the way, and you can think about my eyes here and the working area here, and just shaving a small portion of the disc and a small portion of the bone here in order to open up the canal. This is often allows for early mobilization, walking on the day of surgery, and in some patients is appropriate for outpatient surgery. Here we have multiple different diseases that can occur within the spine. So we have different types of spondylolisthesis. So you can see here is that this is that slip that we were talking about. And once again, this can be a fixed slip or it can be a mobile slip. This is a grade 2 spondylolisthesis, which is divided into 4 or 5 grades, and it is pretty severe. And I would expect, without seeing even an MRI, that the patient would have severe symptoms with what we call neurogenic claudication, which is associated with spinal stenosis. This would most likely come with complaints of pain radiating down the leg and with complaints of difficulty ambulating any sort of distance. Here we have degenerative disc disease and just some subsequent stenosis. You can see degenerative disc disease here and also spondylolisthesis here. Here you can see a previously fused segment and arthritis developing in the adjacent segment. And here you can see what we call degenerative scoliosis, which is scoliosis that develops during juvenile adolescent age, but not during adolescent or juvenile age, occurs later in a person's age, and it's because of the asymmetric breakdown of the discs. You can see here that there are multiple different ways to address the spine. So this is a cross-section anatomy. The belly is up here, the back is here, and the sides are here. And we can approach from 4 different regions for the lower back. Now, some of these techniques are old, and some of these techniques are more new and are more minimally invasive. So the first one here is anterior lumbar interbody fusion. So this is going in from the front. So we'll go back to this slide. And you can see here that you don't actually go straight through here. This slide is actually not accurate. There is a special pocket that we can move out of the way, and we can minimally invasively get to the spine. This allows us to reduce something like a spondylolisthesis or that mobile slip that we spoke about. It offers a very large cage, which increases the chance for fusion and allows us to fix the alignment and make the alignment much better than many patients have had for years. It's also very good if a patient has osteopenia or is on the verge of having osteoporosis, because it gives us a larger surface area, a better chance of fixing the problem and keeping the fusion. The downsides to this procedure is that you do work next to major vessels, but some areas of the spine are best approached from this approach. It also is a little bit more invasive, for instance, than the lateral approach that we'll see. But the lateral approach cannot be used for some levels such as the L5-S1 level. A posterior lumbar interbody fusion is good because you only have to do one position. The downside to it is the recovery process is sometimes much longer, and there sometimes has increasing back pain because to get to this area, we have to shave and move all of the muscle out of the way. You have to retract the nerves, and this can leave patients with radicular pain from nerve inflammation and motion, and can leave them with pain that they didn't have before. In patients that have had abdominal surgeries, in very large patients, this may be more preferable, for instance, than the anterior spinal fusion. As you can see here, the cage here is very small. It's much more difficult to correct deformity to allow for a fusion to occur afterwards, and it is not great for patients that have osteopenia or osteoporosis. A transforaminal lumbar interbody fusion is a more minimally invasive approach than the posterior lumbar interbody fusion. It uses a very small cage. It is difficult to restore the alignment. As you can see, the bone window is very small, so there is an increased risk of not attaining a fusion and holding the fixation that you have. And the muscle has to be moved out of the way. There can be new pain, and you have to move the nerve roots out of the way. You don't have to touch the nerve roots or enter the spinal canal with an anterior lumbar interbody fusion. And if a patient has had a previous microdiscectomy or laminectomy, there is a decreased risk of dural tear with an anterior lumbar interbody fusion or the lateral base procedure that we'll discuss. This is the lateral base procedure. It's called an extreme lateral interbody fusion. It's really not extreme at all. It's actually a minimally invasive technique that is short in hospital stay and is very effective for lumbar levels, usually from the L1 to L5 level. You're able to correct deformity, place a very large cage, and able to attain fusion at very high rates. The majority of my patients that have this procedure are able to leave on post-op day number 1 or post-op day number 2 and have a great relief of their back pain and their leg pain. The downside of this is that we do go through the psoas muscle, which is a main hip flexor. We use intraoperative nerve monitoring to make sure we stay away from the nerve roots. And it does have a large benefit as we do not have to move the nerves out of the way. We do not have to dissect the muscle in the back. And if there are any rods or screws that need to be placed through the back, they can be done through a minimally invasive approach through incision that's slightly greater than 1 inch. This is a very good comparison here, so you can see all of the different techniques side by side. An XLIF shows a very large cage, and this is the one where we enter from the lateral side. You can see the size of bone graft that we're able to place. An ALIF is a very similar idea, and this can be used primarily for an L5-S1 level. And a PLIF shows these bilateral cages here, small but effective, and it is tried and true. It's been used for many, many years. You do have to remember that you have to move the muscle and move the nerve roots out of the way here. And TLIF is the same idea, which is that off the back posterior kind of procedure to place this cage. Once again, a small cage, retraction of the muscle and dissection of the muscle, and moving the nerve roots out of the way. So outpatient lumbar microlaminectomies are used and can be outpatient procedures. They're good for certain patients that are generally healthy or that their main medical problem is their spine issue. Anterior cervical discectomy and fusions can be done in an outpatient setting as well, 1 or 2 level fusions. And this is once again patients that are generally healthy. Their major problem is their spine problem. They don't really have any heart disease and no other major medical problems. The nice part about coming to Sutter and using their surgery center is that you get your own nurse, you get your own room, and basically you get the space to yourself with very minimal people around for the evening that you stay overnight with us. So For post-op, walking is really the main exercise. In all the surgeries that I showed you today, we get patients up and walking on the day of surgery. It is a requirement. And what I tell my patients is we do the first part. We do the part with the surgery. We open up the nerves, and the nerves in your body have to do the rest. And part of that has to do with walking, physical therapy, and slowly returning to your normal activity. Spinal precautions are limiting twisting and bending, and not lifting more than 10 to 25 pounds after surgery, depending on the procedure that you have. Physical therapy goes through all of this in the day of surgery and the day after surgery, and we make sure that our patients are quite safe before going home. There's a gradual return to normal activity, and depending on the surgery, it can be at about 4 weeks up to about 3 months. And surgeon preference decides if a patient wears a brace. I like to give braces to most of my patients because I want them to go out and walk, and I don't want them to have a problem with not being able to walk farther or do more activity in their postoperative period, which increases their ability to feel like they are progressing. And decreases their chances of getting a DVT or clot after surgery, and decreases overall the complication rate. This is just a generalized kind of idea of what the hospital stay for certain procedures are. An anterior cervical discectomy and fusion, which is the neck surgery that we showed in the very beginning, has a 1-night hospital stay and maybe a 6-week recovery. A microdecompression it can be an outpatient procedure or an overnight stay with a 4-week recovery. Microdiscectomy is very similar. Lumbar fusion is 1 to 2 nights, although I have had patients leave after 23 hours. And the majority of patients are walking on the day of surgery, and they feel a great deal of relief in their symptoms of radiating pain, although of course they have post-surgical pain. These are just some testimonials just off of our website. I cut and paste them. Kind of just looking at the fact that, you know, spine surgery is not equal. Spine surgeons are not equal, and all patients don't have the same problem. And here's just a discussion about why to choose Sutter Santa Rosa Regional Hospital. So one thing that's not here is that every patient does get their own room. They have a great deal of understanding on how the recovery of a spine patient goes and what to expect, and they have a lot of experience. They have comprehensive patient education program with a coordinator as well, and they're right across the parking lot from my office, and we do track all of our outcomes in order to try to improve outcomes the best that we can. So we'll go ahead and just take some questions now.
All right. I think, Dr. Athanassious, if you can hear me, you can stop sharing your screen so we can see your lovely face. And we'll go ahead and have some questions for you. The first question is, can a pinched nerve in the neck cause numbness in my hands?
Yes. So if you remember that dermatome map that we saw earlier, a problem at the, for instance, the C6 nerve root can cause a problem with the thumb or the pointer finger. It can cause pain to radiate down. And sometimes there's compression in the neck, but there also could be compression in the elbow or the wrist. If you think about a nerve like a pipe with water in it or a hose, the garden hose can be compressed in the neck, and it can also be compressed downstream from that. And the combination of compression in both places can cause pain, numbness, or tingling, or weakness.
Great. We have another question. What do you see as the determining factor in choosing fusion over laminotomy?
So it's a pretty complex question. One determining factor that we just spoke about in terms of the discussion that we had is if a person has a actual instability in the spine, it's really not indicated to do just a laminectomy or a microdecompression without fusion. When you take away ligament, even if it is arthritic and pathologic, that can cause that instability that's already present to become worse. If it's just an acute disc herniation without a problem with stability, If a person has primarily symptoms that occur when they're standing or walking, that can be just laminectomy alone. It is a case-by-case basis. We look at multiple different factors.
Very good. Next question is, how do you feel about nerve ablation to relieve pain?
So nerve ablation is good in very specific circumstances. If the person has facet-oriented pain, they've had a medial branch block, and after getting the medial branch block, they have excellent relief of the axial back pain, which is back pain just in the axial skeleton. A radiofrequency ablation is good. If a person is doing radiofrequency ablation to try to alleviate radicular symptoms going down the buttock or the leg, the anatomy doesn't work that way. It usually does not work.
Great. I'm not sure I can pronounce this one, but the question looks like, how do spondylolisthesis and retrolithesis differ?
They don't really. So it's talking about the direction of the slip. A spondylolisthesis can also be called an anteriorlisthesis, which means that the slip is moving forward. A retrosthesis means that that bone, that reference point, is moving back.
Okay. The next question is, will the lumbar surgery help me with my bladder and bowel problems?
So it really depends. Some people have bowel and bladder problems because they developed Takata Quina syndrome. That's something that needs to be treated right away within 72 hours or less. If it's a problem where the pain in the back is so severe that a person cannot empty their bladder and they're feeling like they need to go, or when they need to go immediately, that can be something that may be helped with bowel and bladder. What I would recommend is seeing me, and also we can correlate that with the urology evaluation to take a closer look at that problem.
Very good. Next question is, if I have degenerative disease in L4 and 5, but little pain, how often should I be x-rayed and examined?
So I would say that it's not something that you need to come in just to be x-rayed. I think that you should keep your, get a baseline, come and see a spine specialist, have them take a look at you, do an exam. Then after that, we can educate you in what to look for and when to come back. It's not something that's a matter of every year you need to come in, or every 5 years, or every 6 months. It's really understanding what to look for and to know when to ask for help.
Great. Our next question is, if one has contact pain on one side of the neck, stiffness but no headache, how do you ask for an x-ray? My PT says I should ask.
Yeah, so you just ask for the cervical spine films. We would get a front view and a side view, and sometimes we'll take a look at what we call flexion extension views to see how the neck dynamically moves. Another way of looking at things is just to get that for those first 2 views and see how things look. The surgeon will take a look at it, or I could take a look at it. We have x-rays in our office. If I need more, I can get more. You don't need to worry about getting x-rays before you come in. We have an x-ray in our office.
Very good. Next question is, can sleeping on an elevated bed used for acid reflux cause neck and back pain?
Sure. There's all sorts of cases where patients will have a change in mattress, have a different pillow, have surgery and have to sleep in a different way, or have surgery and have to walk a different way. And now that is throwing off their spinal balance, causing irritation in the nerve roots. And that's bringing possible problems that were actually present in the spine earlier, but weren't brought to light because there wasn't this different way of sleeping, different way of walking, or change in balance.
Great. Can pinched nerves and stenosis cause cramping of your legs, hands, and feet?
Sure, of course. Stenosis is a simple term that means narrowing. So if you imagine if there's narrowing anywhere in the cervical spine, that can cause a problem in the hands or the feet. If there's narrowing in the lower back, that can cause a problem in the lower back or down the legs.
Good. The next question is waiting for a laminectomy as my age increases a problem? My pain is fairly minor at the moment, but I'm 75 and a type 1 diabetic.
So I would encourage you to come in to be evaluated and to be looked at. Not everybody needs surgery, but it's good to keep an eye on things and to watch how things go. I always tell patients, you're the youngest you are today. So we need to evaluate what's the impact on your life and what kind of surgery will we need to do and what does that recovery look like. A constellation of those factors brought together help us make a decision. And together, you and I help make that decision with me educating you the best that I can and answering the questions and getting a feel for how much this is affecting your quality of life.
Great, thank you. The next question is, I have osteoarthritis in my back and neck with clicking. What do you suggest?
So if it's not with pain, it's a difficult thing to truly evaluate and treat. What I tell most of my patients, if the clicking is painless, I really wouldn't worry about it. We can, of course, get x-rays. We can be educated on it, but nobody's going to do surgery because there's some clicking in the neck. The chance of fixing that problem, the risk and benefit is not great.
Great. Next question is, how do you make an appointment and how far out are your openings?
So I think that we are scheduling a few weeks out into July right now. You can call my office, you can fill out the survey afterwards, and we can reach out to you. We're happy to do that.
Great. Next question is, what is spondylosis?
So spondylosis is just a simple garden variety term that describes arthritis in the spine. It can be the arthritic facet joints that we talked about. It could be the degenerative disc that we're talking about. It's another way of expressing arthritis within the spine. So when you say that a person has lumbar spondylosis, it's just a garden variety arthritis within the lumbar. It can be in the cervical spine or in the thoracic spine.
Very good. The next question I can actually answer, and it's, will this recording of the program be available for review? And the answer is yes. At the end, there's a survey. So just make sure you take it and put your email address in there, and we'll get you out the link to watch Dr. Athanassious' presentation again. All right, our next question is, I have a sleep number bed. Should I keep the legs down after surgery?
Down after surgery. I would tell you to keep the legs in whatever position is most comfortable for your back to get you your sleep. It's really important to get sleep after surgery. We know that people that are sleep deprived have a sensation, the same pain sensation that comes from the back or surgical site will feel to us much more painful and much less manageable. So whatever position is most comfortable for you, I would recommend.
Great. Our next question is pregnancy often a cause of sciatica?
It's not often a cause of sciatica, but pregnancy releases different hormones, which causes a kind of laxity in the ligaments across the body. It also causes an increased amount of fluid retention. So we often hear about people having sciatic symptoms or carpal tunnel, for instance, during the time when they're pregnant. Additionally, the increased baby weight does throw off the spinal balance, and it can last past the term of the pregnancy.
Great. Next question is, I have been seen by you and a laminectomy prescribed, but can you cure this without surgery?
There is, if it is spinal stenosis, it is unlikely to actually have a long-term durable treatment without actually surgical treatment. We know that if problems are not fixed or don't resolve themselves in about 6 months, and really on the high side of that a year, they're not going to be fixed on their own. And the most likely thing is the pain will continue and most likely get worse over time.
Okay. Next question is, do you do QME exams for work comp cases?
I do not do QME. I will do a what we call a permanent stationary evaluation, but I do not do QMEs at this time. You need to be certified for it, and I haven't taken that certification.
Thank you. Next question is, what is severe degenerative arthritis in the facet joints?
So the facet joints are smooth. If you think about joints, they're usually very smooth surfaces with a small amount of liquid inside. Severe facet arthritis is speaking most likely about that smoothness not being there, and also a deformity or enlargement within the facet joints. That can cause axial back pain. It can also, if it's large enough, cause spinal stenosis, which is that feeling of pain radiating down the legs and tiredness when a person walks. It can also cause radiculopathy, which is the pinching of the nerve as it exits from that neuroforamen or nerve hole that we spoke about.
Great. Our next question is, does your clinic have physical therapy modalities?
It does. Our Mark West office on the 3rd floor of the Sutter Medical Office Building has extensive physical therapy modalities that are very good at all musculoskeletal treatment and are very well versed in spine physical therapy, pre-op, post-op, and just treatment of back ailments. We have PhDs, we have people with a master's degree, and we have bachelors of science all in the same building there.
Very good. Next question is, my mom has a disability and doesn't understand some things. Would I be able to be there before surgery to help with any questions?
Of course. Right now during our COVID time, I'm happy to call patients and put them on speakerphone. And we can, of course, do a case-by-case basis in situations like this.
Great. Any enriching diet you recommend for backbone spine health? Question.
There is no special diet. I just tell all my patients, make sure you have a well-balanced diet, use a multivitamin as you get older. And that's not just for spine health in terms of arthritis, but in terms of trying to protect the best we can against osteoporosis and problems with age.
Okay. Next one is, I'm 74 years old. For occasional lower back pain flare-ups, is it okay to take approximately 1,000, I think it's probably milligrams or grams Tylenol and 1,000 ibuprofen for several weeks? I have no GI side effects. My primary care doctor is concerned about kidney and liver damage. Should I worry?
So that's really up to your primary care doctor to continue to take a look at your labs. Over a few weeks, and I don't know all your health history, should not be a problem, especially if you don't have liver or kidney disease. But we know that anti-inflammatories can cause gastrointestinal problems. They can cause problems in terms of raising blood pressure, and that needs to be carefully looked at.
Thank you. Here's another one. What is the cause of weakness in a thigh if one stands still in one place for more than a few minutes? Walking alleviates that discomfort immediately.
So it's very hard to give you an answer exactly regarding that. It can be foraminal stenosis, which is that nerve hole pain. So most people, when they stand, they kind of lift up their head. They actually have pretty reasonable posture if they're standing in place. When they walk, they kind of tilt forward. They open up those the neuroforamen by tilting forward, and they feel like the pain is alleviated. So a lot of people say, I can't stand in place. I can't sit in any place for too long. I have to get up and move around. It's because of that standing and that slight tilt that you have when you walk.
Okay. Next question is, it's been 1.5 years since my last MRI and I have not improved. Should I get another?
I think you should have me take a look at it or another spine surgeon take a look at it, and we'll decide. We need to evaluate you. We need to see how things have not improved. Have they truly just gotten worse? Is there worsening in terms of your physical examination symptoms? And that'll give us an idea. We can also get x-rays and compare the x-rays that you have in the office to your older MRI to see if there's been much change.
Great. Thank you. Next question. Thank you for all these good questions, by the way. Next question is, realizing that walking is good to help back issues, what do you do if it hurts too much to walk any distance? Should I consider taking a pain medication just in order to walk?
So that's pretty reasonable, but I would definitely recommend you come in and you have it looked at. That's a very typical presentation of spinal stenosis. That presentation is called neurogenic claudication, which means nerve pain when walking. And it is a very common thing that we treat. We treat it with the modalities we talked about: physical therapy, epidural steroid injection, and even just an overnight procedure. And often what I hear from patients after they've suffered with these kind of pain for years and years, that they wish they had done it years previous.
Here's another good question. For somebody who has 25 or more pounds overweight, would losing the weight help alleviate back pain?
So we know that loss of weight will help with back pain problems. It may not be the only problem that is, there. Of course, losing weight will take pressure off of the core muscles, will allow a person to have less pressure on the discs. But there may be a constellation of symptoms in addition to obesity or increased weight that can cause back pain.
Great. Another question. Are there other options without surgery? Steroid shots, anything else you recommend?
Sure. No, all of those are all steps along the way to the appropriate treatment for your back. When we take a look at, and I kind of alluded to this earlier, patients come in with multiple different problems. There's many different ways to address that problem. Some patients are okay with a certain amount of discomfort, even a certain amount of numbness or weakness. They can live with that. And we kind of guide that. And We get that sense from our patients, we educate them, and we give them a treatment modality that is appropriate for them. Some patients are very bothered. They're very active and they need a better functional outcome. Those patients may require epidurals or they may require surgery. It all depends on what the quality of life is, what the expectation is, what's the patient's general medical history, and what is the likelihood that we can give a person a very good outcome with just physical therapy or epidural injection or surgery.
Great. Next question is, can you do anything for spina bifida? There is also spondylosis and degeneration L4 and 5.
So most likely the spina bifida is not the cause of your pain. Those other pathologies that you named definitely could be. So we need to take a look. I probably would not do something with spina bifida alone, but if those other modalities are causing a problem, there can be many treatment options.
Next question is, what are your best recommendations for stretching yoga and Pilates and weights?
So I don't really have recommendations regarding that. What I encourage my patients to do is kind of discuss with the physical therapist, what are the activities that you enjoy doing? And the physical therapist can help tailor those activities, those stretches to be something that can be done at home on a frequent basis and that can be maintained over time. And the physical therapist has a little bit more knowledge in terms of those kind of activities and has just a good amount of time to be able to look at a person's musculature, how they stand, where they're weak, and be able to address those concerns.
Great. Next question is, would my post-op surgical care be easy for tending to by my daughter?
Yeah. Yeah, we have many people that don't have anyone at home. They go home and they convalesce by themselves. We make sure with every patient that they're able to walk, get in and out of their house, do their activities of daily living before they go home.
Right. Here's another question. What does tingling in your leg mean?
Yeah, so it can be this spinal stenosis term that we keep referring to. It could be within the center canal or it could be out the nerve hole. We'd have to take a closer look with x-rays and MRI, but that's certainly, if it's radiating symptoms, if a person has back pain, it can certainly be coming from the back.
Great. Here's another one. Can physical therapy be done out of office?
Oh yeah, for sure. So what I tell all my patients is that physical therapy is not something that's meant to go indefinitely. You go 1 or 2 times, you go home and you do the exercises, you get good at those exercises. You go back to physical therapy, you get more fine tuning, more exercises, and you progress your care. And eventually, you don't need the physical therapist. You know what to do, you know what works for you, and you do that on a daily basis and you keep your spine healthy.
Great. And this next one is, what kind of massage would you recommend for flare-ups and or maintenance?
So there's no recommendation of massage. It really is what feels good for a patient. I do ask patients to kind of hesitate away any strong manipulation of the cervical spine. But if massage therapy works, if acupuncture works, if chiropractic care works within the lower back, it's not unreasonable to try it.
Good. What can be done for neuropathy?
Lots of things. All of those things that we talked about, people are diagnosed with neuropathy by maybe an emergency room doctor or a primary care doctor. And they can sometimes be from the spine, but they can be sometimes from other medical problems. A B12 deficiency can cause neuropathy. Diabetes can cause neuropathy. So we'd have to look and see. And once again, we take a look. We look at what the complaints of the patient are. We look at the x-ray and the MRI findings. We think about our physical examination. We listen to our patients, and we bring those all together. And when those line up, our ability to treat the patient and have predictable, reliable, excellent outcomes is increased.
Very good. Next question is, do facet joint injections or ablations do much good? And is there a serious risk to doing these interventions? Over time, does the injection material cause its own damage to the areas? Or if not done too often, is the damage not a serious concern? How often is too often?
So I would encourage you to speak to your pain management doctor about that. That's usually the person that does facet injections or radiofrequency ablation. The risk is not high with these procedures. These procedures are especially good for treating facet-related axial back pain. However, if a patient has neuroforaminal stenosis, central canal stenosis, degenerative disc disease, spondylolisthesis, the treatment modalities are not as great and they do not work well because the anatomy just doesn't make sense.
Good. Next question is, as one ages, can cervicogenic headaches, dizziness be reduced or prevented? What scenarios would qualify for surgical intervention and what might be done in this regard?
So for my patients, I make sure once again that the history, their complaints are relating to the x-ray and the MRI. I look for physical examination findings such as weakness, numbness or tingling in the upper extremities that correlate. And we talk about what are the chances that a person's headaches will be relieved from a cervical procedure. And we sometimes will do a diagnostic and therapeutic epidural steroid injection in the cervical spine to see if there's any relief of symptoms, even if it's for a short amount of time, to better be able to predict what surgery can do.
Good. Here's another good question. As a person gets into their 70s, 80s, and 90s, is there a point at which even daily stretching, moving, or physical therapy can't prevent the type of chronic neck and or back symptoms that bring patients to doctors?
No, I mean, everyone is different. Everyone has different genetics. They have different life situations. They maybe worked in different professions. And all of those things come into play. Some people will never have to see a back person or spine person, and they don't even have back pain. Some people are not as fortunate, and the stretches and daily exercises don't work in the long term.
Great. Next question is, please speak to the use and safety of ibuprofen and extra strength Tylenol, 500 milligrams, in a combination treatment of back and neck pain for patients who do not have adverse reactions to those drugs. What are the maximum dosages, length of use, monitoring, etc.?
So I would encourage you just to, because every anti-inflammatory is different. So I would ask you to look at the back of the anti-inflammatory and make sure you're not going over the maximum limit. If you don't have kidney disease or liver disease, it's pretty safe to take these medications. Also, if a person doesn't have a history of ulcers or gastrointestinal disease or bleeding, it's probably pretty safe to take these medications. All of these medications really should not be taken more than 2 weeks to a month. If they are, they need to, the reason for the back pain needs to be evaluated. In terms of Tylenol, this is cleared much differently. It's cleared through the liver. I encourage patients to take less than 2,500 milligrams a day. The real limit is about 3,000, but I want to keep it far below that in order to keep patients safe. Once again, if a person has pre-existing liver disease, it's not indicated and not good to take these medications in the long term. And once again, as with the anti-inflammatories, if a person is finding that they're taking this for 2 weeks, 4 weeks worth of time, they need to come in to be looked at.
Good. This next question says, the good doctor, I'm assuming that's you, diagnosed me with severe spinal stenosis. After 2 bilateral epidurals with Dr. Yang, there is a good relief, but it's not complete. The question is, will spinning on an exercise bike worsen my spine? It certainly helps with the heart health, but I'm trying to avoid surgery.
It's not going to worsen your spine. In fact, it probably feels better. That hunched over kind of posture that on a spin bike or a stationary bike is actually opens up the spinal canal and probably allows you to spin much farther than you would be able to walk.
Great. Next question is, do certain joints in degenerative disc disease, cervical and or lumbar, have a higher observation hotspot? Are certain ones likely to regress than others?
Observation hotspot? Can you just read it one more time?
Sure. It says, do certain joints in degenerative disc disease, cervical and or lumbar, have a higher observation hotspot? Are certain ones likely to regress than others?
It's kind of hard to understand the question. I would tell you that the most common levels that have disease in the cervical spine are C5 and C6, and the most common levels that have disease in the lumbar spine are L4, L5, and L5S1. I'd encourage a little more clarification or come in and I can definitely answer that question.
Yeah, and I'll also say that you can, when you have the survey that pops up at the end of this, just type in the question and Dr. Athanassious will get back to you. Another question is, what do you think of meloxicam as an anti-inflammatory?
It's fine. And once again, I just don't ever prescribe these things for more than a month without a serious look at what's going on.
Right.
These are not meant to be long-term medications that are taken for a lifetime.
Another question is, after surgery, how often should I go for a walk?
As often as you feel you're ready. If you're one of my patients, get walking.
Another question is, does itching have anything to do with leg tingling?
People feel it differently. Itching is not the most common of complaints that people associate with the spine, but I've heard all sorts of ways that we perceive this kind of compression on our nerve roots.
Next question is, I am over 65 and assume there is degeneration in the spine that's just a fact of life. Is the pain and tingling feeling close to the surface felt in the band of tissue that runs straight down the center of the lumbar sacral spine, likely posterior stenosis ligament? Did I get that right?
It's probably, that could be part of what's causing the narrowing on the spinal canal if you have spinal narrowing. Arthritis is a constellation of symptoms, and the spine has multiple different bones with multiple different joints at each level. The posterior longitudinal ligament is one of those ligaments that can thicken, and it can cause spinal stenosis and pain.
Good. Here's another one. As one ages, can anything be done about the thickening of the ligament, this ligament, and can surgery be an option for this if there's no stenosis showing on MRI or radiating pain into the limbs?
Sure. There's definitely treatment options. We'd have to look at that unique case and take a closer look. But yes, that thickening that you're talking about is a very common ligament called the ligamentum flavum. It is often thickened and stenotic in patients that are suffering from spinal stenosis and describing the symptoms of neurogenic claudication.
Great. I think we're done with the questions. If people haven't had the opportunity, at the end, they can put them in the survey. We'll have a big round of a virtual applause and thank Dr. Athanassious and our webinar audience tonight. We hope you've learned more tonight and you've come out knowing more than when you signed on. And once again, just a reminder that when we conclude tonight, the survey form will pop up in your browser window. And thanks for giving us the feedback on the presentation. And also you can ask additional questions, contact the doctor with anything personal, or request an appointment. And just in case that survey doesn't pop up, it will be available in an email that we'll send out tomorrow. So check your email. Thank you all for joining us. Have a great evening and best of health. Have a great night.
Thank you very much.